Hi, good afternoon, and thank you all so much for joining today's panel on the COVID-19 outbreak underway in Hong Kong right now. My name is Dan Strumpf. I'm a correspondent governor board member here at the FCC. I'm also a reporter with the Wall Street Journal in our bureau in Hong Kong. We're joined by two really eminent and local experts on this issue to talk about this this crisis currently underway in the city. Just a couple housekeeping notes, just to kick us off. We welcome your questions. Please do send those along. You can send those just throughout the event to question@fcchk.org. Send those in email form to question singular at fcchk.org, and we've already got some questions lining up now, so those will come to me, and I'll get those to our guests. So we've got two outstanding experts here. Dr. Ivan Hung sends his apologies. He was unable to join us at the last minute due to a last minute meeting, but we've got two great experts that it's my pleasure to introduce now. We have Dr. David Owens and Dr. Karen Grépin. Dr. David Owens qualified in medicine from Leeds University in 1984. He's been working as a doctor in Hong Kong since 1988. He's also an honorary clinical assistant professor in family medicine at HKU and the chief medical officer of the Hong Kong Rugby Union. He's one of two founding partners at OT&P Healthcare, a chain of private clinics across the city. David has an interest and bias towards public health, originating with his early experience of HIV in the 1980s. He came to Hong Kong to work in tuberculosis. He was previously the deputy editor of the Hong Kong Journal of Family Physicians and has written numerous articles during the pandemics of both SARS and COVID-19. Dr. Karen Grépin is an associate professor at the School of Public Health at the University of Hong Kong. She is trained as a health economist and conducts comparative health policy and health systems research. Dr. Grépin's research focuses on institutional factors affecting the demand and supply of health services and government policy response to infectious disease outbreaks. She has a Ph.D. in health policy from Harvard University, an SM in health policy and management from the Harvard School of Public Health, and a bachelor's of science in immunology from McGill University. Thank you both for joining us. So today's panel is titled Hong Kong's New COVID-19 Reality. To combat its fifth wave of COVID-19, Hong Kong has instituted an unprecedented series of new social distancing restrictions, but with cases reaching new heights, the highly contagious Omicron variant has presented a fresh challenge to the city's efforts to contain the virus's spread. What measures can Hong Kong still take to bring the latest outbreak under control? Can the city balance epidemic control with the economic costs of the latest measures? And will Hong Kong be forced to abandon its dynamic zero COVID strategy and take a more accommodative approach? So these are the questions that are going to guide this discussion. And again, please do send in your questions as well from the audience, because we all have a lot of questions on this issue right now. So let's kick off with I think just the most pressing question that everybody has on their mind right now, which is, can this outbreak that's gripping the city right now be brought under control? And what does control even look like? More than 7,000 new cases yesterday, according to the government figures, but though even the health authorities have admitted that they can't, that they don't have a full grasp of the situation given the backlog in testing. And just now was released a study by HKU, which is modeling 183,000 daily cases by the end of March, and more than 100 daily deaths as well. So if that's to be believed, we still have a long way to go here. David, do you want to kick us off? I mean, you know this study, you saw it. What does the future hold for us here?
Yeah, I mean, I think the first question, can Hong Kong bring this wave under control? And the answer is no. And I don't say that negatively, but rather to say that I think the narrative around control is unfortunate, because control and containment, and we hear this quite a bit, the government talking about the fact that it's going to take 2 to 3 months to bring it under control. And Omicron is going to burn through. It's the nature of the virus, it's biology. It's going to burn through in a period of 2 months to 3 months. And whether it's 2 months or whether it's 3 months will be influenced as to how much we can mitigate. That is to say, how much we can minimize the damage by flattening the curve as we talk about, which means it will be, last longer, and the infections will be spread over a longer time, and that will take pressure off the health system. So actually, it's really important that the narrative switches, in my opinion, away from control and elimination towards mitigation, which means we accept we can't control it, so we have to mitigate the damage that it does. Now, the study that you mentioned, Hong Kong University has actually some of the world's leading disease models for infectious diseases. And Kathy Leung put out, who's one of the lead authors in that study, put out this morning a sort of addendum to the original study, which came out 10 days or so ago. And it's important to understand what we do with modeling studies is we have various inputs. And depending on those inputs, we project different scenarios. So when the first study came out, I think if you remember, the focus was very much about lockdown. It was like, we're going to have a lockdown. But in fact, I think that was a misunderstanding. What the study actually said is, if we go for scenario 1, which is we have the level 4, as it's called, which is the social distancing regulations we have at the moment, we anticipate X happening. If we were to release those on February the 23rd or whenever it was meant to be, we would anticipate Y happening. And if we did a lockdown, we would anticipate Z happening. And so the models were given under different scenarios. And the sort of addendum that came out this morning, and this is my interpretation just from reading it this morning, and a brief interaction with Kathy, who's one of the lead authors, is that over the intervening 10 days, the modelers are saying, look, we've relooked at the data, and the level of social distancing regulations we have at the moment has reduced movement within the city and has reduced contact points within the city to a lesser degree than we'd anticipated. And so when we replug in the fact that it didn't do as good a job, it's in very simple terms, it means that the wave is going to be sharper, higher, and steeper. So it's going to peak in early to mid-March rather than mid to late March. And as a result of that, the numbers at the peak are going to be higher in terms of the infections per day. And the ballpark figures there, if you looked at under scenario 4, which is our current lockdown, and I'm going from memory from reading the data, but it was around about 1,000 deaths predicted as a baseline. And the model this morning is saying that's going to be around about 3,000. So it's saying that even with a baseline, if we carry on doing what we're doing and we don't do any more, there's going to be a higher number of deaths. We're going to have a shorter, sharper wave, and it's going to put greater pressure on our health system. And I think my own interpretation of that is that makes it even more important that we urgently change the narrative from controlling and testing and to mitigating and putting all of our energy and resources and efforts into minimizing the harm that this inevitable wave is going to cause. We will not control this.
Yeah, I mean, I think I agree entirely with what David is saying. In fact, I think, in many ways, what I would say is a lot of the damage has already been baked in, right? There's actually very little that we can do at this point to dramatically shift the way in which this outbreak is going to play out, right? So the time for that has passed. not only would I frame this as mitigation, because I think that's a challenging thing for people to understand, I think there really is sort of two things that we should be clear on. Right now, the priority is about saving human lives and about protecting our healthcare system so that it continues to function through the next couple of months. We are at such a critical stage at the moment. It is very likely that our health system will collapse. We will not be able to provide sufficient care and resources for the people who will have COVID in the coming weeks and months. Not only that, we will not be able to provide routine health services for people who have other health conditions in Hong Kong. This is not a good time to have a heart attack. This is not a good time to be going through breast cancer treatment. This is not a good time to have a car accident. Right? These things are real. And so the priority for government and for our response to COVID right now should really be shifting toward saving human lives and protecting our healthcare system.
So, against that, against that context, is in your view, is this shift to mitigation that I think both of you seem to agree on happening? Is it happening with enough urgency? Are you seeing any initiative in that direction? And we all know the sort of frantic pace that new isolation facilities are being built right now in the city, and assistance coming down from the mainland on testing. But is any of that enough? Are things moving in the right direction? Karen, do you want to start with that?
Sure. So I'm going to say no, right? So, and the reason for this is, again, we have to think about this idea right now that priority should be saving human lives. I think the one thing that we could still really double down on that could make a really big difference in the coming weeks is vaccinating our elderly. I still have not seen the level of urgency, the level of intensity, the level of ingenuity that we have seen over the last week from government around, for example, building isolation facilities. We have broken ground on new facilities to build 10,000 beds. We have somehow found 400 taxi drivers who are going to be shuttling COVID positive patients to healthcare facilities. We've seen none of this to try to dramatically increase vaccination rates. That is the one thing I think that could really make a difference in terms of saving human lives, and that could still be done in the coming weeks. And so I just, testing, isolation, these are important things, but these are things if your goal right now was to reduce transmission, that's where I would put my energy. But if my priority right now is mitigating and saving human lives, I think the priority should be different at this time.
Yeah. David?
I totally agree with Karen in everything that she said there. Firstly, we know from other health systems and from other health crises that when hospital systems get overloaded, all-cause mortality increases multifold at all ages. So there's a lot of talk about vaccination in children, for an example. I think horrible way to think about it, but the greatest threat to a child in our city is not COVID. It's something else. It's that the hospital system gets overwhelmed and the child becomes ill with a otherwise treatable condition such as asthma. And so the protection of the health system should be our first, second, third, fourth, fifth priority. And vaccinating the elderly and vulnerable is still the most effective way to protect our health system, because the more vulnerable individuals are the ones who go to hospital, and they're the ones that overload the health system. And there are also some structural factors. And I take Karen's point that, I think if I'm understanding this correctly, she's sort of saying, look, we're a bit past mitigation. And I think it's true. It's about protecting the hospital system. In order to give you a narrative to sort of get your heads around what's happening here, I see a problem being associated with the fact that the government policy is, the narrative is one way. It's still talking about zero COVID or dynamic zero COVID, or which is effectively elimination, which is an old strategy. And under that strategy, you want to test people, you want to identify all of the cases, you want to isolate them in quarantine, and you want to minimize any infections in the community. Once a disease has escaped, once you pass that, you have to sort of change tack. Metaphorically, the fire is burning. We're not going to stop it. So now we should put all of our energy into making sure it does the minimum amount of damage. So, as examples, having people standing around to do tests in the rain for a result that's going to come in 6 days is of zero value. We could have all of those people giving vaccines to the elderly and vulnerable. Even building isolation centers, I think that's great. It may be that's going to be very, very helpful if we use them to house less unwell people who can't live in their own accommodation, because we have to understand many people in Hong Kong can't isolate at home, or at least if they do isolate at home, they'll put risk to other people. But really, the narrative needs to shift so that anybody who's asymptomatic stays at home. Anybody who's mildly symptomatic stays at home. Anybody who can't stay at home because of their risks in their own home or their environment, yes, they should go to an isolation center or a hotel. And the money that we're spending on PCR testing, we should just get it all, just stop it today, right now, stop it all, and let's transfer everything to rapid tests. Give every single home in the territory rapid tests so that they can test their children, people can test before they have to go out to work. For key workers, everybody else stays at home. This is the sort of plan that you would have in an aggressive pivot to mitigation. And that has to start with communication, to explain to people, we are in a serious situation here. We're going to have an accelerating epidemic. We're going to have many, many people going to hospital. We're going to have people dying over the next 2, 3, 4, 5 weeks. And this is what we need to do to make sure that those numbers are as small as possible. We have to start communicating that narrative immediately. Sorry, I felt strongly about that. Apologies.
Karen, you've done a lot of work studying different approaches to COVID from by different countries and different cities. Is there a model in your view out there that Hong Kong could successfully follow, given where it's at right now? And what are the odds that we'll get that?
Yeah, I think this is a really important question. We had literally 2 years to think through this kind of a question, so that when we were eventually faced with the fact that COVID would enter into our community, we would be prepared. I think there have been some more successful examples of this than others. And I don't think, for example, we're going to learn a lot from looking at Western countries, the United States and so on, countries that have had very high levels of ongoing community transmission for over 2 years. But some of the models from across the Asia Pacific region, in particular, countries that were formerly zero COVID and for a variety of reasons have now decided to make this transition into living with COVID. I think some of them could represent important models for us. To be clear, I think even if the Hong Kong government was interested in the future pursuing a zero COVID strategy again, then the priorities in the short run have to be the same as those for attaining zero COVID in the long run. We have to get the number of cases down. We have to minimize the health impact, all those things. But for example, where we see places that are transitioning, there's a lot of planning that goes into this idea of what does it mean to live with COVID, right? So in the context of Singapore, this was the planned strategy that they started last summer. They, for example, a lot of effort went into what the Minister of Health there called getting people psychologically prepared for this experience, right? We just spent 2 years telling everyone that COVID is the worst possible thing, that the consequences of getting COVID will be very, very dire. How do you convey to people that if you get COVID, if you're vaccinated against COVID, you will be fine and you will get through this, right? So there's a lot of that. There was also enormous amount of preparation gone into, for example, everyone in Singapore received a pulse oximeter so they could monitor their own status at home. Everyone, telehealth and telemedicine centers were set up in order to provide care for people who are safely isolating at home. Enormous health communication. We've seen similar things, I would say, in places like New Zealand. Australia pursued a somewhat different strategy, and it does vary very much by state within Australia. You know, wide spectrum of approaches there. But the key message is that there was a thoughtful process gone into the preparedness aspect of the transition, and thinking through the consequences, and therefore planning and thinking ahead of what might happen in those different scenarios.
Great. Good food for thought. So I want to actually we're getting a lot of questions in from viewers. So actually, maybe we'll cut away to a question from a viewer. It's from Vanessa. Vanessa asks, has the Hong Kong government, in light of the excellent suggestions being brought forth today, has the Hong Kong government canvassed your views and actually taken any of your recommendations on board? Who is leading the direction and narrative? And I would add to that question, I mean, are you satisfied with the extent to which the government authorities have listened to the expert community? Not sure who wants to take that, but David, perhaps you want to jump in?
No and no and no, I think.
I mean, you know, in a little bit of defense, you know, my area of expertise is actually countries outside of Hong Kong, right? So most of my research over the last 2 years has really focused in particular on how sub-Saharan African health systems have been dealing with the pandemic. But no, I've never had any communication with government in terms of thinking through some of these things. I also have to say out loud that I think I've also been kind of concerned throughout the response of the lack of disciplinary diversity in the way in which the government has been seeking insights around the pandemic. For example, over the last year, you know, lots of wonderful academics across the city who really understand issues around behavior change, issues around health information, around reasons why people might be vaccine hesitant. I didn't see a lot of that being consulted to think through some of these issues around vaccine acceptance and uptake in Hong Kong. Whereas we see a lot of people who have medical backgrounds and microbiology backgrounds really making a lot of that policy recommendation. And so I think it's been a limitation of the way in which the response here in Hong Kong has been so reliant on a biomedical view of what is important in setting policy.
I think, can I just say, I think that's an excellent answer, Karen, much better than mine. But I wrote an editorial in 2003 during the sort of, actually towards the end of the SARS pandemic in a journal of family medicine, and critiquing the response at that time. And I could publish it again today by just changing the name of the pandemic. And the main critique was really one of the last points that, and I think there is a structural issue within Hong Kong that the power base, even medico-politically, tends to be the disease experts. So, Hong Kong has some of the world's leading public health virologists. If you look at some of the research that's come out of Hong Kong University and other universities in Hong Kong, and not only in, I think the point that Karen made is really important, not only in public health, also in engineering, and some of the stuff that's coming out in terms of the modeling for aerosol spread and the psychological expertise in behavior change, all of that sort of stuff. But even if we look at public health itself, we had some of the world's leading disease modelers, public health experts. Hong Kong University, 3 of the specialists from Hong Kong University wrote an editorial in the British Medical Journal. I think it was around about July or August last year, which is titled Towards Managed Endemicity, which was effectively the sort of, the game plan for doing what Singapore has done. So it's not that we don't have the expertise in Hong Kong. We've got lots of expertise in Hong Kong. It's that the experts tended to be experts from hospital disciplines and hospital specialties. And I don't know. I've discussed this on many occasions, and it's hard to think of an example, but it certainly doesn't really make sense to me.
So I want to, Karen, well, you both brought up the issue of vaccination, and this is often a point raised by policymakers in Hong Kong that's been shaping the response that, Hong Kong sort of, across population has a vaccination rate, I think in the neighborhood of 70% or so, correct me if I'm wrong. But among the elderly, it's a lot lower. And this has been the real issue that's held up Hong Kong's opening up with the mainland and elsewhere, and it's been the issue now, of course, that's growing in urgency as cases spread. What happened here? Why is that vaccination rate so low? Why do we lag in this really critical area behind other countries, and how do we get that number up? Can it be brought up at this late stage in the game?
David, do you mind going first? I'll go. That's fine.
Go for it.
The answer is there's not one thing, right? It's and this is a lesson we've taken from all around the world, but it's not one single thing. When I woke up this morning, the first thing I read was that a man named Dr. Paul Farmer passed away, who is a medical anthropologist based at initially at Harvard, but also Partners in Health. He coined the phrase, and I'm going to put something out there that might be a little bit controversial, but structural violence, right? And the basic idea is the way in which society is constructed means that those that people who are most vulnerable, are most sensitive people in society, because of all of these different factors, end up being worse off than those with the means, those with the power. And I think this is a good way of framing it. So I think it's a question around the way in which vaccines have been politicized. I think the way in which vaccines have been incentivized. I think the way in which health information, I also say it, I think the way in which media has framed some of the side effects early on with regards to vaccination. I think even the way in which Hong Kong has a very broken primary healthcare system. It relies almost heavily on the private sector, no offense, David, for primary healthcare, and created incentives, for example, for this concept of health checks, which doesn't exist anywhere else in the world before you get vaccinated. All of these factors have contributed to these really low rates of vaccination, particularly amongst the elderly, who I think have really been taught to believe that vaccines are not for them. And in a world in which we have had no COVID for such a long time period, that was plausible. But of course, one had to have an incredibly high discount rate on the future to understand that situation wouldn't ever change. And so that's the situation in which we're now struggling with the fact that all of these factors contributed to the fact that we have very, very low rates of vaccination amongst the people who most need vaccines in Hong Kong.
Mm-hmm. David, you've written a lot about this issue too. What's your view?
Yeah, I agree with Karen. I mean, one of the things, there's things that we can learn from all over the world, and a couple of the things we can learn from the US. One is it's a very, very, very bad idea to politicize a public health response. And the second is that it's really important not only how many vaccines you give, but who you give them to. So if we look at broadly across the world, there's really two groups. There are the countries that pursued elimination, which is China, Hong Kong, Macau, Taiwan, Singapore, Australia, New Zealand. And we know we know without shadow of a doubt that was the best policy for the first part of the epidemic. It was the best in terms of saving lives, and it was the best in terms of minimal impact to life and socioeconomic function. And then in the other parts of the world where they had to suppress and lift, where there would just be let it burn to a varying degree and then bring in public health measures to try to control the waves, we've seen great differences in in outcomes from, some that have really done poorly, like the US, and some have really done quite well, like Denmark. And so having a suppressant list strategy isn't invariably associated with a very bad outcome. But if we look at the ones that have done better and the ones that have done worse, politicizing is bad. High trust in government and engaged population with education and buy-in from the community is very good. And then vaccinating to a high level, but most importantly, from the highest level down. So, if we look at countries like Denmark, they're way above 90% from the very elderly. If you look at something like the US data, actually the vaccination rates are not that bad, but they're sort of giving them to the wrong people and haven't quite reached the key threshold. The difference between 60, 70% and 80, 90, 95% is key when we're dealing with something that's so transmissible as Omicron, because, well, there are factors in the mathematics of epidemiology that mean that the more transmissible virus, the higher the threshold you need. So in Hong Kong, in many ways, we're a bit closer to that US model. We've got high numbers of people, but we've sort of given them to the wrong fragment. We haven't given them to the most vulnerable, and we haven't given to the most vulnerable down. I think Karen touched upon the many complex issues that play into that. I think one around the narrative is, I think one of the things we'll look at as from public health going forwards is, if you have an elimination strategy, so in this case zero COVID, having elimination without any plan for exit is a fundamentally different strategy to having an elimination with a plan for exit. So we look at Singapore, probably the best example. But Karen would have more expertise than I, but I can't think of anybody else who's done it quite so well in terms of communication planning, structure of a transition. China may yet do equally well, but later on. But from our perspective, we had a narrative around closed borders and elimination, and I think that maybe it wasn't inevitable, but it became negative. It became around keeping things out, around quarantine, and we saw the negative narrative around the breaches of everything from aircrew to hamsters. Became the bad guys, and I think that negative framing then played into the side effects from vaccines, and I think I may have even coined this. Ben Cowling and I have had numerous conversations about it. It triggers rational vaccine hesitancy. It's rational to not take a vaccine. I used an analogy once. I might go to West Africa in the next 10 years. When am I going to take my yellow fever vaccination? I'm not going to have it now. I'm going to wait until a month before I go. And if you're telling people you're not going to have a disease and it's not going to happen, there's no incentive for them to be vaccinated. So there was a narrative around elimination without an explanation that this is only a waypoint for the future. It's only a transit, and eventually we need to move on. So that to me was a major factor, was the narrative around zero COVID.
Do you feel as though either of you feel as though vaccines have risen in priority in terms of the government response now, have been given any kind of greater urgency, sufficiently greater urgency in light of what's happening now, or do you feel as though it's still kind of taking a back seat?
I don't think enough has been done. No, we have seen a increase in vaccination rates over the last couple of weeks, couple of months.
Yeah, that's right.
Yeah, I think I was quoted in Bloomberg last night saying, if you double a small number, it's still a small number, and it's how I feel with regards to the elderly. I don't think we fully have addressed the issue around vaccine hesitancy, right? And I don't think it's a supply issue as much as some people say. I think there are some issues out there around people getting access and being able to get into clinics and stuff. But I think the more fundamental issues around vaccine hesitancy have not been addressed here in Hong Kong. I think a lot of people genuinely still believe that they are poor candidates to get vaccinated. And I think a big reason for that is that that information has come to them from people that they trust. And those people that they trust are typically their healthcare providers, their family members. You know, one of the important lessons that we have learned throughout the pandemic is trust is incredibly important in any government's response to COVID. I think we're at a stage right now that I'm not sure it should be a government-led initiative necessarily either to think about how to address this issue, given we do have relatively low levels of trust and that they've been, if anything, declining over the last couple of weeks and months. So I think we have to work with what people trust, right? So coming from the medical professionals, which have always had, you know, really high levels of trust amongst Hong Kongers, and people do really trust the information of their family members. I think that is where we need to focus our energy if we want to really see the kind of meaningful change in those numbers that we really need to protect human life in Hong Kong in the coming weeks and months.
Could I just make a point that I think, you know, just I agree with all of that, but I do think that there is a supply access issue at the moment. I mean, we, you know, I give vaccinations. We give vaccinations in our clinic, and we're booked up until end of March. There are, you can't get into a vaccine centre now. So I think hesitancy remains an issue, but we saw this in Australia and in New Zealand, and there's nothing like an exposure to the illness and the reality hitting home for driving vaccine rates. So I would really like to see all of those compulsory testing resources like stopped immediately and turned into vaccine centres. And that's, you know, we could jab 90% of the elderly within a week if we put our minds to it. This is Hong Kong. We know we can build an airport in a year.
Great. So want to turn to another audience question, actually getting a lot of questions that are quite practical in nature. So let's turn to a few questions here from the audience. This question comes from Lee Hawley, an FCC member. Lee asks, given recent studies that have shown significant prevalence of long COVID, including amongst asymptomatic and people with mild COVID infections, even those who are vaccinated, what can vaccinated individuals do to proactively reduce the likelihood of long COVID from breakthrough infections, specifically in terms of prophylaxis and early treatment to accelerate rapid and full virus elimination? David, do you want to grab that one?
I think your single most important preventative strategy for long COVID is vaccination. We have really good evidence for that. So to be vaccinated and boosted, it doesn't prevent completely, but it's for sure the thing that eliminates it the most. We don't have enough data on those factors. Really, we know that it's a multi-system inflammatory condition, and it's going to be something that's going to be long term. I suspect that viral load is going to be implicated. So not being exposed to high levels of infection, which, you know, at the moment means masking and social distancing, I think are the things that we can do. I'm not aware of anything else that you can do that's going to reduce risk. I mean, you know, eating healthily, getting a well hydrated, sleeping, all of those sort of things, which boost immune function. But I'm presuming the question wasn't sort of moving around with things like you know, ivermectin or that type of stuff, because definitely not for that. I mean, I think there's no evidence for other interventions that I'm aware of.
Right.
I won't comment.
Okay. Another question from Sarah Borwine. Hope I'm pronouncing that right. She also kind of has some similar questions as well. What treatment protocol is being followed in Hong Kong? Are we using monoclonal antibodies as places overseas are? She also asks, if you had a 5-year-old, which vaccine would you recommend? You know, David, I think that's maybe another one for you.
Oh, Sarah, you're toying with me now. Sarah's a colleague and great expert in her own right. So,
there you go.
It's a tough one. I still struggle a little bit with the vaccination question, Sarah. I have to be honest with you. I think it's very easy if I put my public health hat on, because the public health hat tells me that we should be giving all of those vaccines and jabbing them in the arm of an older person. Because, like I've said earlier, the greatest threat to a child is the damage to the health system. We've got an increasing body of evidence that vaccines are safe and effective. We've got a lot of evidence from 12 and above, increasing evidence for younger children. I was always a little bit cautious about rolling out large vaccine push out in young children without huge amounts of international evidence. I know the UK has just started giving it, haven't they, to 5 to 11-year-olds, and there we have a trade-off where we have greater short-term data on BioNTech because we've given millions of doses and we've got really very, very good data against the Sinovac, which is a more traditional, we could say, vaccine, which is effectively inert other than the adjuvant. But we don't really have solid safety data on it. So I think that's a hard choice, and to me, it has to be a decision that every individual parent makes. I can understand why doctors are advocating vaccination for all children, but equally, I can understand why parents are reluctant to give vaccinations to younger children. If it was me, I'd probably give BioNTech, just on the grounds that we know that it's a more effective vaccination, but I can equally understand the counter. Sorry for sitting on the fence there. I think vaccination of young children is a really difficult question, and I find it much easier if I could metaphorically put my public health hat on and say, give them all to the elderly. In terms of the, sorry, Karen, keep going.
No, I was going to say, I thought you were done, but I was going to say, I struggle too. If I put my health economist hat on, I would agree with you. But I'm also a mother, and when I put my mother's hat on, and the fact that my children have sat out 50% of the 3 last academic years and are not returning to school this year again, I feel like my children deserve something. And so I did rush out and get my kids vaccinated on the first day that BioNTech was available in Hong Kong. Even to the point where one of my kids didn't have an appointment and I just walked in and begged. So, for me, the decision was very easy. I think the message here is all of these vaccines are super safe. And, where we have seen some issues around myocarditis in the teenagers and so on, we've got more information about any vaccine ever given in the world available to us. And to me, the evidence is so clear on, and if I had a 4-year-old, I would give them Sinovac, because I think we just don't yet know all the full consequences of what these illnesses might do to our children in the long run. And so for me, given that there's such a good safety data, I don't see a lot of downside in taking that risk.
Could I just add, I think that's a very good point that Karen made at the end, that what we do know is that long-term effects of both short-term and long-term effects of the disease are significantly greater in the unvaccinated than the vaccinated. So, I mean, one reason that I didn't mention, and Karen did mention, to vaccinate a child is to prevent those risks of longer-term complications, longer-term COVID, inflammatory conditions, etc. So, I think that's great advice coming from a mum and a health economist, Karen.
Great answers. So I want to just shift the conversation back to something that we touched on at the very beginning, which is I want to go back to that quite urgent HKU study on the supposedly coming wave of cases. So 183,000 cases a day, I think, is the number that study is calling for. I mean, I'm still trying to wrap my head around this number. Does the system in Hong Kong have the capacity deal with that. And you know, it sounds like, judging by the way this conversation has gone, the answer is probably no. And if not, well, then what? What do we do? What do individuals do, and how do we sort of best look out for ourselves?
Could I just answer the first bit of that, and then Karen's
Sure.
probably best placed to deal with the other issue. But I think in answer to, you know, quite possibly coming, it's not possibly coming, it's coming. Okay, this is a message to get out. Certainly, I mean, dealing with journalists, this is coming over the next 4 weeks, and let's say there's an attack rate of, I would estimate it's probably going to be 70%. It might be a bit less, it might be a bit more. But, you know, we've got a population of 7.5 million. There's going to be 5 million infections in our territory in the next 3 months or so. So that's not, you know, maybe possibly sometimes coming, that's what's going to happen. We're all going to get this. And for 90% of us, it's going to be asymptomatic. There was a Lancet study that suggested that from the South African data, up to 90% have no symptoms. And then for many of the rest, it's going to be mildly symptomatic. So for the vast majority of people, to be clear, this is going to be somewhere between nothing, or if you get symptoms, it's going to be, you know, somewhere between a mild cold and a bad flu. And I'm not belittling the importance of this disease process. It's a very important disease, but for most people, it's going to be mild. Some people are going to feel like they've been hit by a bus, but the majority are going to be milder. Small numbers of people are going to run into problems. But Karen talked about her quote to Singapore with a, you know, small part of a small number being a small number. A small portion of a very, very big number can still be a big number, and that's the health system issue. So for individuals, relax, don't panic. It's going to happen, but it's going to be fine. For the health system, that's where we need to change our strategy. And this is, I think, Karen, does that seem?
Yeah, I would agree with that entirely, right? I think if we continue to think of COVID in the way that we've been thinking about it for the last 2 years, the answer is no, we won't cope. That's why we have to start thinking about COVID in a different way in order to get through the next couple of months. This is about this mindset shift in terms of exactly what David is describing, but also knowing when you're not doing well anymore, right? And that's really important. And unfortunately, that means that decision about, you know, when am I not feeling well enough is something that people are likely going to have to be doing at home on their own. And so the real priority is getting the information to people so that they are able to do that. You know, I think it's also a question of, you know, getting the message out that, you know, we should be preparing as people for this, right? So last weekend, I established an isolation plan for my household. We decided which bedroom would be used if anyone tests positive. You know, obviously I have a slightly larger home than most people do in Hong Kong. And so this is a much easier decision, but we have food in place. We have rapid tests in place. I have a pulse oximeter on my bedside table ready to go. You know, I think there's a lot of steps that people could also be taking to think through what happens when you get this. And I think that's what the narrative should be. Most of us will get this in the next 2 months. And what does it take to be prepared for that? And so I think, you know, a lot of attention should really now be on households and individuals of themselves preparing for this. And that kind of mind shift will be really important to get us through this. Right? The system, the way that we've been thinking about COVID in the past will not accommodate hundreds of thousands of cases on a day. It won't. So we have to think differently about COVID.
An isolation plan sounds like a really sensible idea. So, I mean, I guess the elephant in the room is that this is kind of where, you know, the reality of the fifth wave kind of runs into government policy, right? Because, you know, the existing policy is still that we have to, anybody with COVID is meant to be hospitalized, and all their close contacts are going to be quarantined. But I mean, I don't know, that doesn't seem really possible when you're talking about 183,000 cases a day, does it, David? I mean, what do you do?
No, I mean, I think if we're going to continue with the government policy as stated, then we don't need to build more quarantine centers. We just need to take over Shenzhen and we can move everyone in there to quarantine. I mean, it literally is just not going to work. It's not even going to begin to come close to working. And this is the dilemma where the narrative is saying one thing, but the reality is pushing us in a different direction. I took a view a week or more ago that, as a doctor, I have a duty of care to my patients and I have a duty of care to the community within which I practice. So I've given advice to my patients: if you have symptoms, you test yourself with a rapid test. If you're positive, you isolate at home with your family and you stay at home until a minimum of 5 days, or until the rapid test is negative, whichever is the later. In Singapore, they did 7 days, but it's you can make a case for difference. We know from US studies that about half the people are going to be negative by 5 days, looking at healthcare workers. So you can mitigate once you move away from an elimination strategy where you've got this concept that you're going to identify all the positives and put them and all their contacts in isolation, which is impossible. I've said 5 million people. So where are you going to isolate them in 3 months? So you shift it, and you start mitigating. And mitigating means you accept there's going to be damage, but some people just have to work. I mentioned I think it was in a tweet I put out. My son is an intensive care doctor in East London. He stopped testing because he said, "What am I going to do? I mean, there's nobody left to staff the department." So the thing that crashes health systems and crashes supply systems with Omicron is not the severity of the disease, it's the number of people who get infected in a very short space of time. So if you isolate and quarantine your healthcare workers, you've got no doctors and nurses left to run the hospitals. And so you need just a change of plan where, and that's the advice I'm giving to people, is you have to do it in a way that makes sense, which is to isolate at home until you're ready, and then you go out and you just hope you don't get caught in a testing notice, because at some point, the testing notices are going to have to pivot and shift, I believe, unless, and this is a potential scenario which would not be ideal, which is that we continue the current narrative that we can control this and bring it under control, and it's going to take 2 months. And in 2 months, we then try and go back to zero COVID when everybody's already immune. And that remains a scenario. It would be nuts, but it's a possibility.
Mm-hmm. Mm-hmm. Karen, did you have any final thoughts on that?
Yeah, I was going to add, I think, government official policy is still that we have to take a PCR test in order to quote unquote be positive. We don't even count if it's on a rapid test. That, if you look at our diagrams in terms of what we do, if we test positive, we're supposed to, wait at home until we, pending admission until, there's this idea that is ultimately the consequence. In public policy, we talk a lot about having sort of incentive compatible policies, things that what is it we want our population to be doing, and how do we create the right incentives for that to happen? I actually think getting more people tested right now is the right thing. We're constrained on testing. PCRs are gone when there's none left. It's very difficult to get PCR tested at the moment in Hong Kong. I like David's suggestion. Let's just stop that and put that all into rapid tests and make sure that rapid tests are widely available. We want people testing, right? And we want people testing as soon as possible. And so that once they know they have that information, that they change their behavior in whatever way that is for them, right? We want people to do the right thing here, which is to test. Isolation. I don't think it's a bad thing that the government is building these isolation facilities. I just think they should be voluntary. I think there's a lot of people who don't think that they can safely isolate at home. Let them be able to go there. We have foreign domestic helpers sleeping in parks because they have nowhere to go, right? This is how we should be using those resources. But if the penalty, right, testing leads to a consequence. Testing leads to a penalty of me or my family members being thrown in these facilities. It's going to be really difficult, right? So we need to change that incentive. And I think the other question we have to ask, there's a lot of talk right now about, do we need more social distancing in Hong Kong? But I haven't seen any discussion around what is the social protection that has to go along with that, right? Like, people need to work, right? This is David's point. People will need to work in the coming weeks and months. How is it that we can, support people through this? But it's going to be a very difficult situation with almost all of us getting sick and having to stay home in the next couple of weeks and months. How do we support that so that we get people doing the right things?
Great.
Can I just add that I totally agree with all of that, and particularly about the voluntary nature of isolation. Could I clarify maybe, so the mistake in what I said before? I'm not advocating people do not comply with mandated government responses. Now, obviously, that's clear. If you're under a testing notice, you have to get tested, and in Hong Kong there is a legal obligation to report a positive PCR test result. Now, it may be government advice that if you think you've got COVID, that you should be tested, unless things have changed, and I'm not aware of them. As far as I know, there's no regulation to report a positive rapid test. So there are distinctions between those two tests. You have a PCR test, you're in a system under which it's all governed by Cap 599, and there are legal ramifications for complying, not complying, including as a doctor to not report that test. A rapid test is not notifiable. So they are two different tests in that regard in terms of what your obligations are. Is that your understanding too, Cam? Because I don't think that's changed.
I don't know how they would enforce it.
Right. Great. Now, good point. And just so we're all on the same page, so the PCR test is the test that you get at the testing center, and that's sort of the official government test, and then the rapid test is what you do at home with a little kit. That's right. Is that right, David?
Well, that is correct. Although a PCR test is a more accurate test of disease. It's a better diagnostic test, but it can be positive for longer after you're infectious, and so it can give a result which is still positive even though you're no longer infectious. A rapid test is not quite as accurate in terms of making the diagnosis. It may miss a few more, but it actually correlates very well with when you're infectious. So when it goes negative, your risks outside are very, very small. Now, you can do a PCR test or a rapid test in a doctor's office. So, but you're correct, the rapid test is the one that you do at home. But, hypothetical situation, if you were to come to my office with a fever and I was to do a PCR test and it came back positive, I would be obliged to report that to the health department, and you would be obliged legally to follow the ramifications associated with that. If I was to do a rapid test when you came to my office, I have no obligation to report that, and I'm entitled to tell you to go home and take some paracetamol and do another one in 7 days.
Okay. Wonder if we'll see some changes in the rules around that in the coming days or weeks. So we just have a couple minutes left. It's still actually quite a large number of audience questions, so I'm going to have to pick and choose here. There were a few questions around some of these heartbreaking stories of young children and infant deaths in Hong Kong over the last couple of weeks, and mainly questions around what is that about? What is there some kind of explanation for that? For some of those occurrences. And then also there was a question from Rachel Duffel, who asks about the fear for parents of being separated from babies and young children at hospitals. And I'm sure you've all seen some of these heartbreaking, at least early reports that have been circulating about lack of capacity in the hospitals, forcing in some cases, parents to separate from their children who are COVID positive. So, not sure who wants to address that question first, but some questions around children and COVID in Hong Kong.
I guess the first thing to say is that those the poor children and parents, and we obviously all have condolences and sympathies for that terrible situation. And I'm really mindful of not wanting to speculate until we have more evidence. And what I would say is fatalities in children from COVID are very rare. And the commonest cause of fatality in COVID is something called PIMS, which is it's an inflammatory condition, and it typically happens 10 days or a week or more after the acute infection. So these don't really sound absolutely typical of that. So we need to find out what has been going on. And certainly one of my concerns, and I'm not trying to make I have been concerned for a long time about the risk to our reputation of separating children from their parents in isolation and in hospital. And one of the concerns I have about these stories is whether people are, staying at home for too long or are unable to access health services quickly enough, whether it's because the hospitals are overloaded, whether it's because of educational factors, of socioeconomic factors, of access factors, resource factors, all these things that play into it. I really don't know, and we need more information, but it's obviously very devastating, and you'd hope that children would be able to access care promptly if they really needed it without a fear of them being separated from their parents.
I won't add much other than I think this just speaks to what I had said just before, which is about this idea of creating incentive compatible policies. This issue around parent separation has come up over and over again. I did just see just before this seminar started some tweet out there that suggested that there may have been some recognition by the government and HA that they would allow parents to quarantine to be in the facilities with their sick children. So maybe we are seeing some change. But it is exactly these types of fears, which are totally rational and totally predictable, that we should be cognizant of and trying to think through how we want people to behave and how to incentivize the right things and depenalize the bad things.
Great. A great closing thought, Karen. Thank you so much. We could go on for another hour, I'm sure. We've got still more questions. I just want to say this has just been such an enlightening and interesting conversation, and I really, we all appreciate both of you taking the time and joining us and helping to talk and inform the community about this really pressing issue right now. So, Dr. Karen Grépin and David Owens, thank you again so much for your time. We are going to have both of you back at some point, so keep us in mind in the future that there's going to be more panels like this, I'm sure, and as we all know, things are going to move fast in the coming weeks. So thank you again for joining us here today, and thanks to everybody for watching and for all the great questions. Hope everybody stays warm and safe out there. So thank you all again.
Very much. Thanks, Karen.
Thank you. Thanks for filling in, David, at the last minute.
Yes, thank you. Thank you, David.
You saved us.
Appreciate it.
No worries. See you then. Bye.
Bye.
Okay, take care. Bye now.